Where is everybody? Good morning. Welcome to the Department of Medicine Grand Rounds. Today it gives me pleasure to introduce someone who's going to talk about travel medicine. And talking about travel, last week was busy for me. I was in LA in the AIM meeting, and then I was in Washington, D.C. on Wednesday and Thursday and Friday, stranded with the snow. Finally, being able to get a plane to Atlanta and then to Cincinnati, only to drive a rental car from 4 o'clock to 6 o'clock in the morning to make it here on Friday, to round at the VA, go to a clinic, and then go to New York. But the fun part in New York was that I visited with the Hermansky-Pudlak Syndrome Network. Now, this is a syndrome that is associated with albinism, platelet disorders, granulomatous colitis, as well as pulmonary fibrosis. And it was a great opportunity to meet a lot of these patients and their families. And one of the things that they do is that they spend the first 3 hours of the meeting talking about how this condition impacted them for the past year. So you will hear somebody very happy that their wife received a lung transplant, and the next person will be very sad that their daughter died just 3 months ago. And it's an incredible roller coaster, but it was wonderful to visit with these people, understand how they're involved in advocacy and so forth. And then I came back, and last night we had two visitors from national speakers, really, to talk about idiopathic pulmonary fibrosis. We had a symposium at the CTRB building, and that went very well, and a lot of members of the community were there. So that is not quite exactly what you intended about travel, but I just wanted to bring that up. Today is an interesting day because in all of these activities, there was Coca-Cola. On this day was the first time in 1894 that somebody sold Coca-Cola. It's interesting that on this day was also the death in 1929 of Asa Kriegs Candler, who bought the formula for Coca-Cola, and his goal was to make it a national drink. And of course, you know that happened. He became the president of Coca-Cola and then mayor of Atlanta for a number of years. This was also the day back in 1991 of Ragnar Arthur Granit. Died on this day. He was a Finnish-Swedish physiologist who shared the Nobel Prize in 1967 for medicine or physiology for his studies on the retinal nerve fibers and how could they detect different wavelengths of light. But today is about infectious diseases. So I want to remind you about Eugene Lindsay Opie, O-P-I-E, who died on this day in 1971, born in 1873, who is an American pathologist, conducted a lot of studies in tuberculosis and in malaria. He studied the immunology of these disorders and how to treat them. And later on, he worked on how these diseases may be related to carcinogenesis. He was very into his 90s by the time he stopped doing his research. And with that, I'll leave you with Dr. Julio Ramirez, who's going to introduce the speaker of the day.
Thank you. Then today, Dr. Anupama Raghuram is going to give us an overview on travel medicine. And Anu is a member of the Division of Infectious Diseases, our global health initiative, and she's board certified in travel medicine in infectious diseases, and she's also certified in travel medicine, one of the few persons in the region certified in travel medicine. Then if you are going to go to an international trip, you're going to stop by our clinics to get your vaccines and your education. This is going to be, any one of us can give you this. But whenever you return from the trip with fever or any problem, then Anu is going to be the one that's going to see you. And then she's going to, again, she's going to give us an overview on travel medicine. Anu?
Good morning, everyone. So our talk today is going to be on travel medicine for the primary care physician. We have increased ability now to travel. We go from one day we're in one continent, another day we're in the next. So we are coming across a lot of illnesses and diseases that we were not familiar with before. So this has become part of the global community, and we need to be aware of things that are unusual for us. So the objectives for today will be to discuss the most common medical issues affecting return travelers. We will highlight some warning signs of severe disease presentations that you should recognize. And we'll also briefly outline strategies for management of illness in the returning traveler. This will be an interactive presentation. You should have gotten clickers, so please make sure you turn the on-off button at the bottom, and a blue light should come on if your clickers are on. Okay. As far as disclosures, I have none. And let's get started with the first case. So this was a case we saw here. 65-year-old male who's a missionary. He had returned from a 2-week stay in Ghana, and 3 days before he came back, he was having some fevers and myalgias, kept on going, started having worsening fatigue, higher fevers, ended up going to Hardin Memorial. There he was very emphatic that he did not have Ebola. This happened in November at the peak of the Ebola crisis. They did do an initial evaluation and transferred him to our hospital for further management. So what are important questions that you should address in these patients? First of all, you need to know where they are, where they came from. So if you're geographically challenged, like I am, you're going to pull up a map and you're going to look for Ghana in the map, right? You're also going to ask about malaria prophylaxis. He did not take any. You're going to ask where they were. Were they in an open safari sort of situation, or were they in an urban setting? He was in an urban setting. Did they use bed nets, insect repellent? Answer is no to both. And was he in rural or urban areas? He was mostly in urban areas, but going to rural places to preach. Okay? All right. If you look at his labs, I have them all slated out for you. So you're going to notice here some thrombocytopenia, right? Some neutrophilia, some mild elevation in LFTs, and otherwise not a whole lot going on. And this is his peripheral smear, and I apologize. Yes?
For a second, the VA just texted me. They want you close to the microphone because they can't hear you over.
I apologize for the picture. I took this. The arrow's not really pointing to anything. What I want you to look at is this right there, okay? And now you're ready to go for your clickers. What is the most likely etiologic agent? Is it Plasmodium malariae, leptospirosis, acute Hep A, yellow fever virus, or Plasmodium falciparum? Give you a few more seconds, and then we'll stop. All right. All right, very good. Most people chose the correct answer. And so the answer is Plasmodium falciparum malaria. And I'm just going to give you pearls because you don't need to know in great details, just so you recognize. So it's a parasite of the red blood cell. The host cell will be the same size as a parasitized cell. Falciparum malaria, you can have very high parasitemia, as this person had a moderate parasitemia. You can have the low platelets that you saw and sometimes high LFTs. Just to very briefly review the life cycle, you need to get bitten by a female Anopheles mosquito. That's going to inject sporozoites. Those go to the liver. You're going to have multiplication here in a schizont, and that's going to rupture, and you're going to have merozoites in the bloodstream now. This whole phase here is asymptomatic, but when you get here is when you're going to have the fevers, okay? And then this is going to develop further into a trophozoite form, and you can differentiate into gametocytes, and that's what's picked up by the unsuspecting non-infected mosquito to perpetuate this cycle, okay? Other pearls that you have to remember is that certain species of malaria, you can have dormant liver forms, and only one drug treats that, which is primaquine. P. malariae is usually mild, but you can have severe presentations very rarely with an immune complex glomerulonephritis. And remember the fifth type of malaria, which is Knowlesiae, and that's mostly in Southeast Asia. The most important thing about malaria is you've got to pull up your malaria map because it's impossible to know which type is where. So that's what you got to do. You got to pull up your map and figure out which is going to be the most likely form here. And I'm going to go into pathophysiology in the next slide. But diagnosis is basically your thick and thin smear. You need to know what you're looking for, and you're going to look for those ring forms. There are several other peculiarities that you should know, that your ID specialist and your microbiology person is going to help you with. But basically, that's what you need to do. We do have an antigen test that we can do called the Binax, and that kind of points you towards falciparum or non-falciparum. However, really, seeing the parasite is what's going to give you the answer, okay? And we often think of malaria as, okay, people feel bad and they have a fever, but there's this whole other cascade of events that happens in many organ systems that you should sort of know, and that's why this can be a very severe presentation. People who start out looking okay, that night they might be very ill, and that's why we recommend hospitalizing these patients. So if you look at this first graph here, what the parasite does to the infected blood cell, it basically remodels that cell. So that cell is now going to have sticky knobs on its surface, and it's going to stick to the endothelium. When that happens, you're going to have microvascular obstruction and tissue hypoxia, okay? You're also going to have endothelial injury causing blood-brain barrier disruption, edema and hemorrhage, and inflammation. So that's if you imagine that this happens in the brain, that can be a severe presentation. This can happen in any organ. So it can happen in the kidneys, and you'll have renal failure. The other problem with this parasite is that it leads to this chain reaction where, besides this adherence here, the infected cells are going to actually connect to the uninfected cells through signaling, and that's a phenomenon called rosetting. And the problem with that is your spleen is working in overdrive to clear those parasites, and they're going to clear not just the infected cell, but also the uninfected cell. So you have severe hemolysis and severe anemia, okay? And you can also go into metabolic acidosis because as you have less oxygen delivery, you have increased lactic acid, you're going to have breakdown of glucose, and you're going to actually have hypoglycemia. So this is a big chain of events. It's not just a fever and I feel bad. There's this whole process going on in the sidelines. Now, this patient did not have Ebola. He had malaria, but you should consider other things for anemia, jaundice, and fever in the return traveler. So malaria is a big one, but you also should consider your acute viral hepatitis, your yellow fever. Yellow fever is transmitted by mosquitoes as well, and it can lead to severe hepatitis with high mortality rates. We do have a live vaccine that's effective, but because it is live, you cannot use it in certain populations. So pregnancy, immunocompromised folks, you can't get that. And you can also have a vaccine-related illness, but that should be in your differential. In leptospirosis, but again, you would expect to have much higher bili than this patient had. And usually you have to have the correct exposure to water exposure, rodent urine. We've seen it here in the States, actually in the hospital with a homeless person. Okay, so it's not just a travel thing. All right. As far as treatment, very briefly, for severe disease, you need IV therapy. For mild to moderate, we have several oral options. Treatment usually lasts between 3 to 7 days. And you'll see that very few areas in the world are still chloroquine sensitive. So we're going to stick to most of these other options, your atovaquone proguanil, your mefloquine, your lariam, and so forth, okay? Okay, let's go on to the next case. This case is called "The Sore Won't Heal." This is a 36-year-old IT professional. He was in Costa Rica. He was there for 2 weeks in the jungles and beaches. And he came back and he had this, it started out like a small red papule. And the lesion starts expanding, the center ulcerates, but it is painless, but it's now several centimeters in diameter. So they do a biopsy, and that's what the biopsy shows, and I'll go through that with you later. So what is the most likely diagnosis here? A, spider bite with bacterial infection, histo, cutaneous leishmaniasis, or leprosy. So let's see here. All right, good. Everyone's on top of things here. Okay, so the answer is cutaneous leishmaniasis, and the key to this is an intracellular parasite. Now I'm going to explain to you what these cells. So this is a macrophage, right? And these are the organisms. You will see two things. The red arrow is showing you the nucleus of the organism, and this black arrow is showing a kinetoplast. Kinetoplast is a bar of chromosomal material, and it's mitochondrial DNA, and this is characteristic of this organism. So you need to see that to make the diagnosis, okay? This is transmitted by sandflies, okay? You basically get bitten, then you have development of the different forms in the tissue. It's called an amastigote. And then a mosquito bites, an uninfected mosquito bites an infected person and perpetuates the cycle. Okay? You can have cutaneous forms, which is what this person has, mucocutaneous and visceral forms as well. The diagnosis, this is very important. So we usually ask for help from our dermatology colleagues. You need to order the material from the CDC to actually do the culture appropriately. And you should biopsy the ulcer border because that is where there's the highest activity of organisms. So don't go for the center, go for the border. There is serology available, but that's not definitive, and it doesn't tell you a whole lot. And in endemic areas, they actually have a skin test, much like our PPD for TB. However, it does not tell you if this is acute disease or chronic disease. So it's not really helpful there. And again, you need to see that structure in your biopsy. Okay. Treatment is nowadays obtained from the CDC with your anemonials. You have to treat this for about 4 weeks, and there's potential cardiotoxicity with these regimens. You can treat with amphotericin B, and that does not need CDC approval. And recently, an oral drug called miltefosine has been approved for both cutaneous and visceral forms. All right, the next case is what doesn't kill you makes you stronger. So this is a 24-year-old male, and he's visiting friends and relatives. This is what we call in the travel circles VFR, okay? And he was visiting in India for 3 weeks. He ate from everywhere. He's like, well, I know this. Nothing's gonna happen to me. And 1 week after returning, he comes back with headaches, high fevers, and chills. And these are his labs. So you can see here marked bandemia. Not a whole lot else going on, but his blood cultures were positive for these gram-negative bacilli. So what is the most likely diagnosis? Is it viral gastroenteritis, inflammatory bowel disease, salmonella, typhi, or traveler's diarrhea? He didn't mention any diarrhea, right? So you can cross that off the list. All right, good. So the answer here is Salmonella typhi. The new name is Salmonella enterica serotype typhi. And so if you look at that picture, does everyone know who this sullen-looking person is? That's Typhoid Mary, okay? So very interesting story with her. She was a chronic carrier, so you can have chronic carriers in this situation. For an unknown reason, they found an equilibrium between carrying the organism in high amounts, but they don't get sick. they've developed sort of an immunity to this, and we don't know why exactly. But there were other carriers. She was the most notorious. She was in New York. She worked as a cook. Every family she worked for would come down with typhoid fever, and this was unusual in New York back then. And people started trying to trace back why was this happening. And finally, one of the salmonella researchers figured it out and started going after her. So she would move, and he would be trying to track her down. And this was early 1900s, so there's no computers, there's nothing going on. So he finally tracks her down. She says, no, I am not sick. I can't have infected all these people. She infected about 50 people, and at least 3 died. So finally, they did a mandatory quarantine. 3 years she was in a hospital. They let her go and said, you can't work as a cook anymore. She goes out there, works as a laundress, but doesn't pay as much, goes back to cooking under a different name, and infects more and more families. So finally, she was quarantined for the rest of her life because she refused to wash hands and to not work as a cook. But so salmonella, in her case, she had gallstones. So that's where the organism likes to live, in the biofilm. And so if you have kidney stones, it's going to stick there. And that's what they think was going on with her. So salmonella infection can be very severe, even in immunocompetent folks. There can be diarrhea or constipation, so it's not just diarrhea. Those occur with equal frequency. And sometimes you just have high fevers, okay? And the VFR population is very, very tricky because they have the belief they're not going to get sick. So you always have to think of that, and you always should offer counseling to these folks, okay? There's other issues. So in these patients, if they start complaining of abdominal pain, you need to be doing a CAT scan because they can perf, okay? And you can also have bacteremia very frequently, and you can have endocarditis. Treatment is generally with a 3rd-generation cephalosporin. Quinolones can be used, but there's been reports of increasing resistance, and people might have fevers for days, even despite appropriate antibiotics. And you've probably heard of the pulse temperature dissociation that happens with this, and that's described in salmonella. And prevention, basically you have to do your pre-travel counseling, basic food and water precautions. So we always say this for travel counseling: peel it, boil it, cook it, or don't eat it. We do have vaccines for it. Efficacy is about 60%, and you have 2 options: an oral form, which is live and gives you 3 to 5 years protection, and you have the injectable, which you can use for your otherwise immunocompromised patients. It's inactivated, and 2 to 3 years protection. But basically that food and water precaution is very important for anyone who's traveling outside, okay? Okay, let's go to the next case, and this one is, I have the flu really bad. So this is a 46-year-old male that came from a 4-month mission trip in Haiti. 3 days after he came back, he has all these myalgias, headaches, vomiting, diarrhea. The next day, all his symptoms are worse. He has a high fever of 102. He has myalgias that are worse and worse, and eventually gets this blanching rash and also a lot of retroorbital pain. And looking at labs here, so not a whole lot. Maybe platelets are a little bit lower. Nothing huge here. Nothing really remarkable. But fevers are pretty high, and it's basically the myalgias and that retroorbital pain. So what's the most likely diagnosis? Let's start your clickers. So we have options of influenza, dengue, or chikungunya. This is a tough one. Okay, good. All right. So the answer here, what you would have thought most likely would be dengue fever. So this is another mosquito-borne viral illness, and this mosquito is not the Anopheles mosquito of malaria, but Aedes aegypti. And it is found in many places: Caribbean, South Central America, Southeast Asia. So that heteroorbital headache and that break bone fever are characteristic of this illness. And you can have early on low platelets, leukopenia, and high LFTs. The thing to think about, and I'll go over this in a little bit more detail in the next couple of slides, is dengue hemorrhagic fever. And that is more observed after you've already had dengue before, and then you get infected with a different serotype. Treatment for this is supportive care. However, what I wanted to point out to you is that there are other viral illnesses that can present very similarly. Of course, influenza, you're going to expect some more of the respiratory symptoms here. And chikungunya actually is very, very similar to dengue. It's the same mosquito, but it's just a different viral illness. And this is called bent-up disease as opposed to break-bone fever. And the areas that this happens can overlap with dengue. So this actually has to be in your differential too. The main difference clinically is that the arthralgias are very debilitating. You can have very swollen hands, and those arthralgias can last for weeks and even months. So it's really hard to tell them apart just based on clinical picture, because they can be very similar. But basically, you need your serologies, and you sometimes need to be sending blood to the CDC and getting some PCRs here, okay? And going into the pathophysiology of dengue, so this is very interesting. So the initial infection, you have, this is mostly talking about the hemorrhagic part. So the problem with this is that you will be immune to the serotype you were infected with, but if you get reinfected with a different serotype, the antibodies that you have available to you, they're unfortunately non-neutralizing for this other serotype. And they actually facilitate entry of the virus into the cell. There's some degree of molecular mimicry here, and you're going to unleash this whole series of events, including activation of your complement system, production of antiplatelet antibodies and anti-endothelial cell antibodies, and you have this endothelial cell dysfunction. It's not, and that eventually causes disruption of your tight junction and capillary leak. So capillary leak is really the hallmark of this. And the problem is that you have, it's more what your body does in response to this new exposure. Okay? And if you look at clinical manifestations, on this side is more of the class just dengue fever without the hemorrhage component. So you see here that you can have early on your leukopenia and your thrombocytopenia. It's the degree of this that differentiates one form from the other, okay? You can have your rash and your bruising. And then with your hemorrhagic fever, you can go into shock, which is dengue shock syndrome, but you can have hypovolemia, low blood pressure, shock. You can have direct hepatic injury, and you're going to see fluid pooling in cavities, okay, with that massive capillary leak and plasma leak, okay? Encephalitis and so forth are less common. And this is the WHO guidelines for figuring out if you just have dengue fever or if you have the hemorrhagic form. So you need to look at several things. Basically, if you live or travel to an endemic area, then you're going to look for fever. Fever always has to be there. And two of these other more nonspecific signs. And you see here this tourniquet test. If you've all seen how that's done, you basically measure the patient's blood pressure first, go to the midway point in the mean arterial, and leave the cuff inflated for 5 minutes. Then you're going to look if there's petechiae there. And if there's more than 10 in a square inch, that's a positive test, okay? So that is what you use to kind of figure out if they have hemorrhagic fever. So dengue hemorrhagic fever, you're going to have the fever, and it's usually 2 to 7 days. You're going to have your positive tourniquet test. You're going to have platelets less than 100,000, and you're going to have hemoconcentration. Important thing to know here is that the dengue hemorrhagic fever, so people start getting worse when they defervesce. So when that fever goes away, you should be monitoring their platelets and you should be monitoring their hematocrit because that can go bad really fast. All right? All right, let's go to the next case. So this is, I just feel so tired. So this is a 26-year-old intern coming back from Peru. He was in Cusco and Machu Picchu and has high fevers and fatigue. He's got the sore throat, just very tired, and he has an exudative pharyngitis on physical exam and some cervical lymphadenopathy. So when you look at his labs, what is remarkable here? You have a marked lymphocytosis, right? You have very high LFTs and alphos, and otherwise nothing really big. And what do you see here? So these are, well, I'm not going to spoil that. We'll see if you can figure it out. So what is the most likely diagnosis here? So your options are infectious mono, oroya fever, or malaria. Okay. All right, good. So the answer here was infectious mono. Then those were atypical lymphocytes that you saw in the smear. So it's very important for you to consider non-tropical cause of fever. The other big thing is HIV, acute HIV in a young person who travels out, comes back. You always need to check for this, okay? So this person had a positive monospot test, but negative fourth generation ELISA, and the viral load was also checked in case this was acute HIV. So for malaria, like I said before, pull up your malaria map. So if you look at Cusco and Machu Picchu, they're right here. They're not in the red, so there's no malaria here. Okay, so just because they're in a place that has malaria, you need to know exactly where they went. So there's no malaria where he went. And then the other thing to consider travel-wise is oroya fever, so Bartonella bacilliformis, a gram-negative organism, and seen on gemsa stain. This is a biphasic disease. The initial phase, you have just the high fever, systemic disease, bacteremia. The second phase is where you have skin manifestations with the verruga peruana, okay? And this can be fatal. But this was not this person's case because that's what he had. Blood cultures were negative. All right, the next case here is called It Has Horns. So this is a 63-year-old female that I saw in clinic here. She traveled to Florida in 2009, but no foreign travel. She says there are several skin lesions on her face, upper extremities, on her back since this return from Florida. She says she's extracting worms from her lesions, and she actually shows you a home video where she's pulling out something from her face. And she says it has horns, and during her office visit, she's trying to dig out another one to show us what this is. So what do you guys think this might be? I didn't put answers here on this one. So this is a case of delusional parasitosis. And though these stories are the most amusing anecdotes, you see many things, there is also a very sad side to these cases. So delusional parasitosis, they actually have a delusion, so it's a fixed belief, and it can be primary or secondary. The primary is that is their only issue, okay? They are functional people, they work, but they have this one fixed belief. The secondary is obviously secondary to a medical illness, usually psychiatric illness, so your manics, or if you're drug use, you get the delusions. The problem with this is because it's a fixed belief, there's no amount of reasoning or talking to them or showing them that is going to convince them that this is not real, okay? So in these cases, what I usually do is if they have samples that they're pulling out or what have you, I send them to PATH to try and show them, okay, this is just skin, all right? counsel the patient, and I very often discuss it with their primary care physician, trying to say, okay, this is what I think it is, and maybe try and convince them for therapy or medicine. This is not very successful usually. And there's also this other entity called Morgellons, and this is a delusional parasitosis, but basically they believe that there are fibers or inanimate objects coming out from their skin lesions. And this is a very active group, the Morgellons group, and they actually lobbied the CDC to look into their disease. And there was a study done, and basically, because they're convinced there's an underlying infectious cause for this. So the CDC did a whole multi-year study, and their conclusion was, these are man-made materials in the lesion. There is no infectious agent. However, I've had a patient who came and said, I have all this, and she says, are you aware of Morgellons? I am. Well, and I said, are you aware of the final findings of the CDC study? And she said to me, well, I don't agree how the CDC did their study. So there you have it. You can't win. But this is a sad side to this. Okay. All right. The next case is there are worms in my stool that look like fettuccine. So this was another case we saw in clinic. A couple who returned from Mexico a week prior. They stayed there for 2 weeks. They sampled the local fare, ate from street vendors. They only drank bottled water, though. And 1 week after they came back, they note diarrhea, and they're also passing these flat yellowish white segments in the stool. And this is, unfortunately, I lost my picture, but it kind of looked like this. Okay. This is obviously from Google Images. So what is the most likely diagnosis here? All right, very good. Okay. So this is a tapeworm, and the fettuccine analogy is very accurate. That's really, it looks flat like that, and like it's gross, but yes. So, and you don't need to know all this. I just wanted to make a distinction between having just a tapeworm and having cysticercosis, okay? So if you look here, this is a disease of poor sanitation because there are stools where they shouldn't be, and then cattle and pigs are eating stools, and so they're eating the eggs. Those eggs then go into their muscle and encyst, right? So if you eat undercooked meat, you're going to have a tapeworm, okay? Now, the other part of this is if you ingest the eggs, then you're essentially back here, right? So it's like you're the pig. And then, not trying to offend anything, but just an analogy. And that's when you get the cysticercosis, okay? So if you eat the eggs, you get cysticercosis. If you eat the undercooked meat, you get a tapeworm. And that's how you explain that vegetarians can have cysticercosis. We had outbreaks in New York in a Jewish community where they do not eat pig meat, and they were all having neurocysticercosis. Why? Because the person preparing their food had a tapeworm, wasn't washing hands, had eggs and stool in their hands, and that got in the food. So yes, a vegetarian person can have neurocysticercosis, and this is how. So if you eat the eggs, you get cysticercosis. If you eat undercooked meat, you get the tapeworm. I know which you'd rather have, but that's how. And treatment for this, I didn't put it on the slide, is praziquantel. Okay. Okay, the next one is worms in my stool, but that look like spaghetti. Okay. So this is a 25-year-old female that passed a visible worm in her bowel movement. She came to the ED because obviously she was freaked out. It was still moving. She spent 6 months in Israel 3 years ago and worked in one of those community living farms. Okay. So what do you guys think here? So this was Ascaris, right? It is the largest nematode or roundworm to infect humans. It probably can reach about 13 inches in size. So yeah, it's pretty bad. This is one of the ones that has the lung cycle. So you will see people, and especially kids, that cough it up, and you can actually see that. I've seen many of those. These guys can also have errant migration into the biliary tract and present very much like a cholecystitis or cholelithiasis picture. And when they go in there to look or do an ERCP, because sometimes it's almost like a pancreatitis, there's the worm and they can dig it out. And again, this is a disease of poor sanitation, okay? And treatment is with albendazole or mebendazole. Okay, this one is called It's Crawling Under My Skin. So this is a 29-year-old male who went to Belize. He did several activities while he was there. He went hiking and wading through underwater streams and did all the stuff that you normally do when you go there. Comes back, has a small nodule behind his knee. It was initially mildly pruritic, but now it's getting bigger and he has a sensation of movement in there. So this is what it started out like, and now every so often, this is what he's noticing there. So what is the most likely diagnosis here? Is it tungiasis, myiasis, or dracunculiasis? And say that 5 times fast. Oh, okay, we have a split here. All right. So the answer here is actually myiasis, okay? So there are 2 different types of flies. One is the bot fly, and we'll do a little video about that. So this is Dermatobia hominis. And there's another one called the tumbu fly. And this you see in Central South America, Africa, and Caribbean, and some hot, humid areas of the U.S. You can see this too. And we'll actually do a little video, and hopefully we have time to do this. This is a very, very interesting parasite.
Blister beetles are not alone in using couriers to take their offspring to food. The young of this botfly, here in Brazil, feed on the blood and tissues of living cows. But how is a female to get them there? She is a big insect, so big that cows would notice if she landed on them and would probably flick her off. She needs a lightweight courier. A housefly, a fraction of her weight. That will do nicely. She drops down to stalk it. She got it. She manipulates the housefly into the right position. And now, one by one, she glues her eggs onto the housefly's abdomen. Within a few seconds, the housefly has been coated by about 30 cream-colored eggs. The botfly releases its hapless messenger. The housefly seems well aware that it's carrying an extra load, but it can't get rid of it. So it goes back to its normal business, which includes visiting cows to drink their sweat. A small fly, unlike the lumbering botfly, is no real irritation and is able to feed largely unhindered. The fly mops up the sweat with its pad-shaped mouthparts, but as it feeds, so the warmth of the cow's body causes the botfly's eggs to hatch. The larvae are armed with tiny hooks, which help them to get a grip on a cow's skin and bore into it. So, in a few minutes, a cow can acquire a dozen botfly larvae, feeding away beneath its skin. Licking won't get rid of them now. A couple of months later, the full-grown larvae emerge and drop to the ground. There they will burrow into the soil, pupate, and turn into adults.
All right. So if you imagine that this can happen with humans too. So if you imagine the human in the place of the cow, so how do you treat this? And basically you have to occlude the hole, the breathing hole, with petroleum jelly and then extract it. And sorry, my bad. And this is it's under a minute.
Quer ver? Ó, ele vai sair, ó. Olha lá.
An extraction
Peraí.
there.
Tô saindo mesmo.
Ele vai... Agora ele tá comendo. Peraí.
Eu vou pegar aqui nesse peixe.
Olha lá, olha lá, olha lá. Que da mãe, cara. Olha, até aqui, ó, Tenente.
Ele saiu tudo de fora, hein?
Peraí que dá pra misturar. Ai.
Yeah.
Ai,
Yeah.
aqui, ó. Olha o tamanho daquilo.
Many of these.
Se o teu tá desse tamanho, o meu tá...
So there are
Só
actually
tem
things
esse aí,
that
tem
crawl
mais.
under your skin.
Não, quer mais aonde?
All right. And, yeah. So the other two options that you had there, so dracunculiasis is the guinea worm, and that is a different worm altogether, and it's transmitted by ingestion of the water with these small shellfish called copepods, and they're infected, and then you drink that water. The worm is going to develop and migrate through subcutaneous tissues until it gets to your lower extremity. It's trying to get out, and it will form a big burning hot blister. And so people want to put their foot in the water to cool that off, and that's when it just lets all its eggs out in the water and everything starts again. So this is very, very long, up to 3 feet long. And if you remember the rod of Asclepius, that's the symbol of healthcare, and they think that it's based on this guinea worm because you have to wrap it around a stick and then pull and wrap around it. It takes days to get that out. The main eradication programs, Jimmy Carter started that, is trying to filter the water when you drink, so you don't drink those little copepods. So that's what guinea worm is. And tungiasis is a sand flea, and basically you can get it on beaches when you're walking barefoot. It penetrates in your foot, and it can lay its eggs there, and you'll have this little lesion with a dark center, and that's actually the flea. And the flea can live in there for about a month, and you have eggs and stool coming out from there. And the treatment is a flea extraction, okay? But what that person had was myiasis. All right, and this is probably the last case, and this is called I Have a Bug Bite. So this is a 60-year-old retired teacher who went to South Africa for a safari adventure. When he was coming back home, and this was a case I had as a fellow, coming back home on the flight, he was having fevers, chills, and fatigue. So from the airport, he goes straight to the ER because he doesn't know what he's got, okay? The only thing he noted was, and of course this is not his picture, but very similar. He had this lesion on his leg, and he didn't know how long it had been there. It wasn't particularly painful. He just knew it was there. He did not take any malaria prophylaxis, and he didn't have really any freshwater exposure or anything like that. So what is the most likely diagnosis here? Spider bite, anthrax, or African tick bite fever? Okay, all right, good. So the answer here is African tick bite fever, Rickettsia africae, and that, again, you got to pull up your map and see which Rickettsia is where. And this is transmitted by cattle ticks in South Africa, and they have this tache noire is characteristic, that black spot, And why is that? Because rickettsia like to invade endothelium, and then you're going to have blockage of the flow there and ischemic necrosis, and that's why the site of inoculation has that scab, that eschar over there. So you treat this with doxy 10 to 14 days. The different rickettsia around the world, the clinical presentation can vary. Some of them are self-limited and you don't really need to treat. Others, so like you hear about Rocky Mountain spotted fever, you got to treat that. This is not as severe. You should treat it to shorten duration of symptoms. As far as differentiating it from cutaneous anthrax, so those lesions that is an eschar as well, but it's very painful and there's a lot of surrounding edema around the lesion. It's not like this one that you saw where it's dry around the lesion and no real surrounding edema. And the brown recluse spider bites can look like that too, but they are very painful. This is more of a painless lesion. Okay. All right. So going to our conclusion. So this increased ability for us to travel internationally requires that us as physicians recognize these other entities that we didn't come across before. And of course, we're always there to help. You distinguish different things. You have to have, obviously, a careful history, a review of the travel itinerary, pull up maps, figure out what goes where, and obviously a physical exam. You need to do a skin exam. You need to have a very careful physical exam. And also consider non-travel related etiologies as well, like that case with the infectious mono. And that's pretty much it. Thank you very much.
That was very good. You do realize that this must be one of the most disgusting ground rounds we've had this year. It still bothers me here. As a child, I remember waking up in the middle of the night listening a truck that would go through the streets, followed by a cloud of something. It turns out I was raised in the Caribbean. They would put this insecticide to diminish the number of mosquitoes. And I remember my parents worrying all the time about having pots that would fill with rainwater because they would be the home for these mosquitoes. And it reminded me that this is really a public health issue, a sanitation issue, and that you can take care of each of these guys who come to your clinic, but the problem won't change until we address the public health issue. And it's also reminded me that perhaps the best investment the United States can make in its own economy and health is really helping other places improve their sanitation and putting resources there for public health. This is a big question, but what can we do to address that situation? Because it seems that it's not by traveling to Paducah, Kentucky. It's by traveling elsewhere. So how can students and doctors in this town make any difference in this other than identifying the individual patient that shows up every once in a while?
So there are a lot of missionaries and mission trips that go out and to treat these. I think with the pediatrics group, they actually go to places. There's a number of foundations that work with this. So Jimmy Carter's one, Bill Melinda Gates. So I think it's just the awareness of that and the desire to go there and try and do something like that, do more. But in education, like if we have patients that come in to me, I try to explain to them, okay, this is how this happens and this is why this happens. Just to plant that seed that, okay, this is how you would approach this, and this is what needs to happen for you not to go there and come back. You went there for a leisure trip, but you got something. So that's kind of how that works, and it is a big question, and it's hard to answer.
Yeah. Questions? Everybody's in awe. I guess everybody's staying in control.
Yes. Mm-hmm. Yes. Yes, and actually there have been cases in the U.S. too of return travelers, and they were looking into if there's transmission from, mosquito and person to person. But yes, it should be increasingly on your differential, because as I said, it's very similar to dengue fever, and the only way to tell it apart is really do your serology or your CDC PCR. The PCR, no, we don't have that. Yeah.
Since Isn't it very interesting when you're involved in this thing, it doesn't bother you so much? Every time I talk to my family in Puerto Rico, somebody else in the family has Uber there for the past 50 years. This is taken over. I mean, it's just amazing how common this is, and at some point it's going to be at your doorstep. This is not just for chronic care. You're going to be into a specialty clinic for somebody being treated for some disease, and they're going to say, I just traveled to this place, and this is what I got.
Yeah.
Do we have a travel clinic here?
Yes.
When is it? Where? How do we get there?
So it's at the 550 clinic. We're open 5 days a week, normal business hours. Just go to the second floor, and there's a big sign there, Travel and Vaccine Clinic. So we're there. Yeah.
Any other comments or questions? If you have something hanging out for you, come to the travel clinic. That was outstanding. That was great.